بسم الله الرحمن الرحيم. It is my pleasure and honor, dear guests. Let me allow me to speak in Arabic to introduce our great guest. طبعا النهارده في سعادة غامرة. احنا معانا زوم النهارده متعدد التخصصات. الدكتور القوسي من انجلترا، مودريتور، طبعا هو متميز جدا في ككلينيشن كنفرولوجيست. دكتورة وسام غني عن التعريف واثرت المكتبه المصريه العربيه والمصريه والعالميه كمان بالنفروباثولوجي سيشنز. لكن انا النهارده هقدم في البرزنتيشن بتاعي استاذنا واستاذ الفاضل الدكتور رياض سعيد. دكتور رياض سعيد زي ما حضراتكم شايفين كده. دكتور رياض حضرتك معايا؟
معاك.
حضرتك اللي شايف التاريخ 68 منور ازاي؟ 68 يوم تاريخ ميلادي.
طبعا ده تاريخ ميلادك.
تاريخ ميلادي. هو حضرتك كنت طبيب يعني، فمعناها ان الخبره عميقه جدا. الدكتور رياض اتخرج من جامعه القاهره، وبعدين كمل مسيره التريننج في امريكا في شيكاغو في الفتره من 72 ل 77. خلالها خد البورد في الميديسن ثم البورد في الكلى، وده حاجه جميله جدا في التوقيت ده ان يبقى فيه حماس. في 78 كان خلص فيلو اوف امريكان سوسايتي اوف نفرولوجي، وبعدين بروفيسور اوف ميديسن اند نفرولوجي في جوردن يونيفرسيتي من 97. وطبعا الصوره دي حبيت ابدا بها لانها بتجمع ما بين قامات متعدده، يعني طبعا استاذ الكل دكتور رشاد برسوم، ودكتور غنيمات طبعا حبيبنا كلنا هنا في مصر بنعشقه، مع استاذنا الكبير النهارده الدكتور رياض بيه. فطبعا الصوره دي فيها ناس عمالقه بنحبهم. دكتور رياض باست تشيرمان الاي اس ان كومجن الميدل ايست ريجون من 2010 ل 2014، كونسل ممبر الاي اس ان في الميدل ايست من 2005 2011. وطبعا اتكللت الجهود بجائزه ضخمه جدا من الاي اس ان بايونير اوورد سنه 2017، وفاوندر الباست بريزيدنت اوف جوردن سوسايتي اوف نفرولوجي من 2002 ل 2006، وفاوندر باست بريزيدنت ارب سوسايتي اوف نفرولوجي، حاجه جميله جدا، اندرينا ترانسبلانتيشن من 2000 ل 2002. دي شهاده البايونير اوورد من الاي اس ان، وطبعا بمباركه طبعا من الجوردانيان سوسايتي ومن الارب سوسايتي والميدل ايست بارت شاب برانش اوف اي اس ان، والناس كلها احتفلت بهذا، وكونجراتوليشن على الجائزه القيمه لنا كلنا طبعا دكتور رياض بيه. طبعا ده المستشفى الدايركتور اوف ميديكال اديوكيشن اند تريننج جوردن هوسبيتال عمان، دايركتور اوف نفرولوجي تريننج بروجرام جوردن هوسبيتال. واعتقد ده في المستشفى دلوقتي. طبعا الدكتور فؤاد في المنتصف القلب، طبعا يعني خير انتاج، يعني خير خلف لخير سلف يعني. وهنا طبعا في الاقصر من 3 سنوات مع استاذ الدكتور طارق الباز اللي هو الاوتم بتاع الارب سوسايتي اوف نفرولوجي مع الكلينيكال نفرولوجي شابتر اوف الجوبنال سوسايتي، طبعا مع الدكتور غنيمات، مع الدكتور فؤاد، طبعا مع رئيس الجمعيه المصريه الدكتور هاني حافظ، الدكتور عمرو حسين، الدكتوره دينا. طبعا هنا حبايب تانيين للدكتور رياض، ويمكن هنا تجمع خطير جدا. دكتور رياض في القلب، طبعا هنا الدكتور استاذنا الدكتور مجدي الشرقاوي، الدكتور حسين الفيشاوي، الدكتور طارق طنطاوي، الدكتور هشام السيد، الدكتور علي طه، يعني تجمع الدكتور محمد صلاح، يعني ما بين القاهره للمنصوره للصعيد كله بيحتفي طبعا باستاذنا الدكتور رياض سعيد. ودي جايزه انا كنت سعيد جدا ان انا شايل له الدرع ده. وطبعا محبين كتير، الدكتور الغامدي، الدكتور غنيمات. نيجي بقى للكونتريبيوشن للجمعيه المصريه اللي انا هارفستد وموجود على السايت حاليا. كم محاضره يا دكتور رياض لحضرتك؟
عدد تقريبا لا مش حافظهم، لكن
لا عندنا لا احنا حصدنا هنا في تبعنا يعني ملكنا احنا 13 محاضره و3 فيديوهات. يمكن ده الهيموداليس انتي كاجوليشن في الشابتر 36 و37 الديت سي دراونينج والالكترود ديستربنس مع الديت سي، وده فيري انترستنج اند اكزايتنج كيسز. ورتوكسوماب ثيرابي ده كان العام الماضي، ودي يمكن صوره اثناء اللايف، والصوره دي صوره بعتز بها لانه طبعا حضرتك بجداره واستحقاق تستحق درع الجمعيه المصريه من طبعا من الدكتور هاني رئيس الجمعيه وحبيبنا الدكتور كمال عكاشه. الحمد لله كلنا سعداء بشفاء، وان شاء الله نبارك له على رئاسه الجامعه. في طنطا، وانا سعيد جدا السلايد بتاعتي كان في الخلفيه اثناء التكريم، فطبعا ده يسعدني. النهارده علشان برضو ما نطولش على الناس اللي معانا، انا سعيد جدا 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 بوجود دكتور محسن القوسي من انجلترا. طبعا هو راجل خبير دولي وعلى علم وعلى يعني عنده اكسبيرينس كبيره جدا في الكلينيكال نيفرولوجي. دكتور وسام نفس الكلام في الباثولوجي، النيفروباثولوجي. وطبعا هيبقى النجم بتاعنا النهارده ضيفنا الكبير واستاذنا الدكتور رياض سعيد. انا هتوقف عند هذا الحد من التقديم واترك لحضرتك المجال to share your slide and start your presentation. انا هفتح لحضرتك الشير اهو، شير سكرين. اتفضل يا باشا.
host disabled attendance screen.
لا 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 لا، حضرتك خش.
اوكي
تمام. المايك مع سعادتك يا باشا، اتفضل.
موجود.
اتفضل.
بسم الله الرحمن الرحيم. دكتور حسين شكرا جزيلا يعني على الكلام اللطيف الجميل. ويعني طبعا مواليد ال 68 حاجه عظيمه جدا. اول شيء اود ان اشكر زميلتي الدكتوره وسام اسماعيل لقبولها ان تشارك معنا في الندوه وهتتحمل عبء الباثولوجي. طبعا all these cases are blind cases. She doesn't know anything about it. فwe'd like يعني زي ما بنقول استبيحوا لها عذرا اذا كان في شويه يعني out of the track ما كانش الرايت diagnostic situation، لانه this is the first time she will know about these cases. نبدا. طبعا اخترنا عده حالات. نبدا في اول حاله ان شاء الله. Our patient he has a recent history of decreased urine output. Can we take this picture side? Rising serum creatinine, accelerated hypertension, and he came in really for evaluation and try to manage what's going on with him. Okay. Now he basically he's a 56-year-old male patient, hypertensive for the last 5 years, well controlled on both calcium agents and beta blockers. He's a chronic user of non-steroidal due to disc prolapse. He's not diabetic, but he is an ex-smoker. His blood pressure became out of control in the last couple of weeks, and it's ranging up to 90, 190, 100, requiring more medication without achieving any help. There was no significant change in his lifestyle for the last 1 year, and no other medication were added in the recent past. He's a middle-aged individual, anxious, but not in acute distress. As you see, blood pressure 150/100, heart rate is 72, afebrile, his weight 68 kilos. Apart from mild puffiness of both eyes and 2+ lower lymphedema, his physical examination was entirely normal. This is his lab. Hemoglobin, quite good, 13.5, white count is good, platelets, ESR and others, but the striking thing that is serum creatinine, when he arrived it was 3.2 milligram per deciliter, and it increased gradually while he's in our area, 3.9 to 4.6. The rest of the chemistry looks not bad apart from the albumin. The interesting is his urine protein 3+, RBCs, 640 red cell by high power field, and he has proteinuria of 4.2 grams. There was red cell cast in his urine. Culture was negative. I displaced this red cell cast really from my teaching file. This is not the patient own because I don't have really how to run, but this is what really represents his urine, red cell cast in his urine. So summary, 56-year-old patient, hypertensive, poorly controlled recently, became more hypertensive, associated with rapid worsening of his kidney function, findings suggestive of acute GN, hematuria, proteinuria, and red cell cast. So our differential really at this point in time was, with this kind of thing, this looks like acute GN, Mostly it is a rapid progressive, whether it's ANCA-related, IgA, post-infectious, something really like this. And we are not ignoring the drug-induced interstitial nephritis. Here, I'd like to ask Dr. Hussein, what about drug-induced and what really the importance of the RBC cast in the urine in this patient?
If you allow me, Professor Riyad, I'd
Yes.
like to give the lead to Professor Elkossi just
Yes.
to have his share. Dr. Elkossi.
Yeah, I'm not entirely sure with this. I mean, drug-induced interstitial nephritis as a differential with this, severe or accelerated hypertension and active urinary sediment. We usually don't encounter that much the active urinary sediments with the red cell cast in the cases of drug-induced interstitial nephritis. So I would go for the, rest of the differential, like the post-infectious, ANCA-related or anti-GBM, IgA nephropathy, but I'm not entirely sure about this drug-induced. We don't encounter that much active urinary sediment. And we don't have even the history except of the NSAIDs for quite some time now, for 5 years. So nothing acutely being given recently to him for the drugs to be blamed.
I like the question of Professor Riyad because as nephrologists, we should put drug as the cause. Even if it is ANCA vasculitis, drugs may cause ANCA vasculitis. So for every case presented in nephrology, we shouldn't neglect drug history. So I agree with the question. It's very valuable to put in mind.
Okay, now let's show this. Well, RBC cast in acute interstitial nephritis. Yes, it can happen. There is a very nice study here, as you noticed in the American Journal of Kidney Disease, 2012, 6 out of 21 patients, recently nearly 30%, biopsy-proven acute interstitial nephritis in one study with RBC cast in the urine. So really, having RBC in the urine, RBC cast, will not really rule out. It still can. This really what indicates, I would like to have from the pathologist now, implies that RBCs which extruded into the renal tubules from the inflamed interstitium can also lead to cast nephropathy. It is well documented in the literature, but is it common? Here, to me, really, that's the only article I came across. What do you think?
Are you asking me? Are you asking me or you asking Dr. Hussein?
Yeah, Dr. Mohsen.
As I'm saying, we are, leading to the common as the common.
Yes.
We usually don't encounter that much active urinary sediment in cases of the interstitial nephritis, tubular interstitial nephritis, drug-induced. It is rare, and as you can see, it is only one. And I would like still to go to the glomerular pathology to start with the presence of the red blood cell cast. And then if this has been exhausted, then I would like to look into the tubular interstitial nephritis. Particularly the drug history of this patient was not that, impressive.
Excuse, if you allow me, Professor Riyad.
Yes.
When we teach, or learn the red cell cast, we used at certain point of time, red cell cast is sine qua non for glomerulonephritis, GN, yes. But nowadays, after some maturity, yes, it is most likely GN, but may be associated with tubular interstitial nephritis as well.
Okay, so that's really our working diagnosis, acute GN. So we have here, both hepatitis B and C were negative, C3, C4 were really normal, ANA less than 180 negative, anti-DNA negative, and both anti-GBM antibody and ANCA were negative. So that's what we have really in this patient. So what other etiologies, and we think now, having exhausted all immunological workup in this patient? Any suggestion?
So biopsy?
The biopsy would say the cryoglobulins are negative as well.
Yes. Okay, let's see, we will go to the biopsy. Now that's the summary of this patient. And we have the biopsy here. Initially, because really lack of time, we treated this patient, and we'll see what will happen later on. We gave him steroid therapy because we are entertaining RPGN in this patient with supportive care, blood pressure control, gentle diuresis, and the biopsy was done next morning. By the way, our biopsy, we do it today. Next morning, we'll have the biopsy reading both light microscopy and the inflorescence. Now, the kidney biopsy, we have a total 14 glomeruli on the light microscopy, and we have immune fluorescence 5 glomeruli for immune fluorescence study. Now, Dr. Wesam, I'm going to start putting the nephrology slides for you, pathology slides. Dr. Wesam?
There is a problem with Dr. Wesam. Dr. Wesam is left. Ah, yes.
No, no.
Yeah,
no,
yeah.
I'm here.
Okay.
I'm here.
Go ahead, Dr.
Okay.
Wesam. Thank you very much.
Right. Okay. So this is a core of cortical tissue, and as you can see, we have obvious chronic tubulointerstitial changes. We have a mild lymphocytic infiltrate, but there is also significant fibrosis, as we can see here. The arteries from this tower look fine, just mildly thickened. There appears no inflammation. And then there is one glomerulus here. And then we need to go on a higher power. Can we have the second slide? Yes.
Yes, we have.
And this is an H&E. Yeah.
دكتور وسام الصوت عندك في مشكلة دكتور وسام.
This is the crescent completely collapsing. You can see.
أنا سامعك كويس.
الصوت ازاي؟
Okay.
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 Then this is again the glomerulus, and you can see that there is epithelial cell proliferation here, and then we have what appears on H&E to be a mildly thickened glomerular basement membrane, but we need special stains. So we have the section. Yes, again, another crescent, and this is the true crescent because we do have fibrinoid necrosis in this crescent, and this is again a slightly crescent. Okay. So this is obviously a glomerulonephritis with crescent. And then we have this artery. It seems like it has some thickening. This is an interlobular artery. Now we have interstitial fibrosis here, and the tubules fine, lymphocytic infiltrate with a lot of eosinophils and plasma cells. Next.
Okay.
Now.
Yes, here with the PS stain, you can see, Dr. Riyad, we need the.
That's the PS stain that we have.
Yes, but there was, yes, this picture, please, thank you. So everybody can see that this is a cellular crescent with a lot of fibrinoid necrosis in it, and that we have some cellularity within the tuft in certain areas. You can see that we have endothelial swelling here and some intracapillary leukocytes. And then the second one. So, again, crescent with fibrinoid necrosis, mildly collapsing the tuft. Okay. So at the level of the light microscopy, this appears to be, it depends on the number of the crescents, but it seems like a crescentic glomerulonephritis.
Okay, it's 9 show cellular crescent, 3 out of 14 total sclerosed, 9 show cellular crescents with accentuated lobulation, 1 appears normal, and focal necrosis, as you mentioned, with the neutrophilic infiltrate, capillary membranes are not markedly thickened. But
no, they are not.
With some fibrosis, element of fibrosis that you have up to 35% fibrosis in the kidney in the area. So, Dr. Mohsen, what do you think?
It's definitely clear from the clinical situation and from the histopathological diagnosis is a rapidly progressive glomerulonephritis. I'm not entirely sure whether there is any other staining of the biopsy at all or not. Say, for example, immunofluorescence.
Yes, we have. I think we are coming to that. So now, having said this, now with the current situation, our differential still will be, is it anti-GBM? Is it really does not look anti-GBM? Is it necrosis, uncorrelated, or immune complex disease? So yes, we'd like to have the immune fluorescence. I just put for you, for our audience, how really the linear, that's the three kinds of anti-GBM, the three types of rapid progressive, that's the linear, as you'll see it. In the middle, we have the granular, and on the left here, we have the Pauci immune. So that's what we expect based on the immune fluorescence. And I found another slide really that's after Professor William Kauser really, we found also IgA, it can be as RPGN with this kind of staining, it's a mesangial staining. So really, it's important to have this stain. Now, as you requested, this is our stain. What do you think, Dr. Wesam?
I think it is clear.
What is this? I can't see the title. Is this IgA?
Yes.
Yes.
So this is, of course, mesangial, very strong mesangial staining for IgA.
Yes. So
And also segmental, and it is present also segmentally in the capillary basement membrane, and this is probably what's reflected on the light microscopy, that we had some segmental basement membrane thickening. And usually within this aggressive cases of IgA nephropathy,
You have big
IgA,
problem, Dr. Wesam. Dr. Wesam.
on the capillary basement membrane, which we consider one of the worst prognosis.
okay, so that's really what we have, as you mentioned. This is IgA, RPGN, IgA related disorder. Now, and that's basically our final diagnosis here, immune complex crescentic GN, IgA nephropathy with significant tubulointerstitial component.
Usually.
Any question about the pathology now and the findings that what we have? Dr. Hussein.
Here there is a question or comment on the chat.
Yes.
These are all cells in the kidney that are damaged in different way. Dr. Wesam, that means she is an expert at looking at the samples from the body and using different stains, colors, and techniques to decide what the disease. I think the question, do you like any other stains or further testing, Dr. Wesam?
Not, okay, Wesam.
Yes, special stains are very important because, you know, we cannot count only on H&E. And Dr. Riyad have shown us at least the PAS, which is one of the most important stains. Having trichrome stain always helps to evaluate the degree of fibrosis, as well as silver if it's available. Can you hear me properly now?
Yes, yes. Yes, Dr. Wesam.
Okay.
Okay.
I tend to agree with you.
So as I said,
special stains are done, and or we have amyloid. It's a routine test in our place. We do it. Silver stain, we don't do it, but we do really the PS stain and trichrome stain. And the four stains we do it, basically PSA, H&E, and the others. But we don't have really the silver stain. Is it really significant to have silver stain in this patient?
I think not. It is not essential in this case.
No. And it's not essential if you have proper immuno and such nice TES, then you can actually do without a silver stain.
Okay.
Since you do immuno routine.
So this is an immune complex crescentic GN IgA nephropathy. Now the question here, what else? Now later on we got some history from this patient just to make it clear, and we have history of recurrent episodes of gross hematuria for the last 25 years following upper respiratory tract, usually within 24 hours to 48 hours and last 2 to 3 days. So the clinical scenario really came completely with the pathology. So it's important always the history, but sometimes the patient or the house staff or us, really, we don't dig deep enough for that. So the clinical history is compatible with the histological finding. That's what we have. Now, how yes.
We have a question. You have a question on the chat. Is IgA codominant infection-related GN excluded?
This patient has no infection whatsoever. You are talking about the super antigen, IgA staphylococcal aureus-related IgA nephropathy. This patient has really, he's not diabetic. There is no evidence of any skin infection, toe infection, or like that, really to make us think about, you know.
And the also, maybe I can just add a little bit of a point here. And the complement obviously was entirely normal.
That's true.
Yes. And the other issue is probably if we can just, make it in summary, if you have got a patient with a rapidly progressive glomerulonephritis, this is for the floor, then you need to have the immunofluorescence to see whether it is a post-immune or is it immune complex related or is it anti-GBM. So might be this is make it more for the staining, the immunofluorescence importance of the immunofluorescence in these cases.
And for the clinical presentation, we have very high creatinine, and we have at the same moment active urinary sediments plus nephrotic range proteinuria or hypoalbuminemia. So it is glomerular, mostly GN, and rapid progressive. And
rapid progressive according to the biopsy, obviously with the
yes.
And then from the H and the E, you can just say that, okay, whether this has been rapidly progressive, is it immune complex related, or it is a post-immune or as anti-GBM, and the immunofluorescence of the IF will be the differential to give us an idea which one the cause.
My comment?
Yes, okay. Let me also comment, because they also added again that IgA IRGN shows capillary walls more than mesangial. No, not a must. It's true, but this case also had a lot of IgA on the capillary walls. But also the light microscopic picture makes a difference. This is not a picture of a proliferative or an infection-related glomerulonephritis. The tufts mainly showed some mesangial proliferation and the crescent. Did not have a significant inflammation to justify. You can have it with an IgE and then you're going to have a problem. But in this case, it was more or less straightforward because you do not have enough endocapillary hypercellularity or leukocytic infiltrate to say that this could balance with an infection-related GN and IgA dominant. While if the light microscopy had shown this proliferative pattern with the crescent and the immuno had shown an IgA, yes, both will fall within the same differential diagnosis, and then it is up to within the clinical context of the patient to judge which one is more likely.
Okay, so
I think one, Dr. Riyad, I think one signal in the pathology, because Professor Wesam commented on fibrinoid necrosis. Is it common to find fibrinoid necrosis in IgA crescentic? I think it is.
No, just let me correct this. The necrosis is in the crescent and not in the tuft. Okay. So you cannot consider it a necrotizing GM. This is just a sign that this is a true crescent.
And if we apply Oxford classification for this case, yes.
Okay, then it will be M1 C2 because this is definitely more than 10% crescent. E1 because one glomerulus had endocapillary hypercellularity. We did not have segmental sclerosis, and we have a T1 definitely because there is interstitial fibrosis and tubular atrophy. So this will be the best score. So okay. M1, E1, C2. S0 and T1.
Very nice, Professor Riyad.
Okay, now how we proceed to treatment for this patient as a clinician, as a nephrologist. Now, Doctor.
This is why I reviewed the clinical presentation, nephrotic with nephritic and renal failure. So in this scenario, you started already with pulse steroid, and I agree about the treatment here because I think the diagnosis here is glomerulonephritis. It is clear from the clinical presentation with renal failure. So starting steroid, I think it is wise decision, and to review us about IgA, because I know IgA nephropathy, there is immune suppression are frustrating and disappointing, but I think the presence of rapid progressive IgA may be an exclusion and to be treated. And as nephrologist, I treat these patients by immune suppressive drugs, by pulse steroids.
Okay, let's go and see, what's really being mentioned here. If we have macroscopic hematuria with acute kidney injury, renal biopsy is mandatory if no improvement within 2 to 3 days of supportive therapy. Because of this finding, you may really be lucky to find acute tubular necrosis, a lot of red cells, red cell casts filling the tubules, or you may see crescentic GN. Not every case of RBG, of acute kidney injury, rapid worsening is basically due to RPGN, but we do see it in this picture here, acute tubular necrosis with a large amount of hematuria and RBC casts. That's from a slide from Dr. Fahli. Now, what we treat, if it is acute tubular necrosis, it's basically supportive measure. If it is crescentic IgA, as in this patient, immune suppressive may be appropriate, and that's a big may really here, because look about here, the study again, Dr. Fahli gave us a nice talk at the Dead Sea. What we classify here, RPGN, systemic vasculitis, 1 year survival, 5 year survival. It's the best. The worst is really crescentic IgA. 1 year survival is less than 50%, and 5 year survival is basically 20%. So it carries a poor prognosis. If we decide to treat, as Dr. Hussein mentioned, steroid plus cyclophosphamide, it's a small study really, not quite impressive, only less than 20 patients, and induction therapy, usually steroid, cyclophosphamide, and then after that, you continue with prednisone orally and azathioprine. Plasma exchange has no proven role for such patients with IgA RPGN. What happened to our patient here? That's a serum creatinine. Gradually it was right.
Dr. Riyad.
Him cyclophosphamide. He received 1 gram IV cyclophosphamide. And then we switched to oral after 2 weeks and then continued here the steroid therapy. Look what happened with his kidney function. We reversed the acute process. His proteinuria gradually decreased, but not really that much. So really what we have here, improvement of the acute situation of the rapid progressive, but still the patient left with his chronic undergoing disease, chronic tubular interstitial nephritis, that really we have no explanation why it happened. I'm sure it's part of the long-standing IgA nephropathy. The patient did well, and basically, he lost follow-up for several years now. That's what we have in this patient. Any comments about the treatment?
Yes, Professor Elkossi. Professor
Elkossi. Add a little comment just for the floor, also to be a bit more clear. I'm not sure about the value of the cyclophosphamide and the azathioprine in these cases. You might have a successful response, and we don't know whether this response is because of the added cyclophosphamide or it is purely because of the steroids only. The evidence for the added aggressive immunosuppressive, like the cyclophosphamide, like any other adjuvant like the azathioprine or mycophenolate, in these cases, the evidence for it is not great, to be honest.
Steroids, I agree.
Yeah, the steroids, yes, definitely. This is one of the, indication of steroids in IgA nephropathy with these cases, also with the nephrotic range proteinuria might be, the steroids will have a place. But to be honest, the cyclophosphamide, particularly, I've given it only single dose. I'm not entirely sure whether the response has been because of the steroids with the anti-inflammatory effect for the crescentic form, or it is because of the added benefit of cyclophosphamide, which might not be, because it can kill the patient, cyclophosphamide, without having this strong evidence.
I agree with you, Professor Elkossi. If I am the treating physician, I am going to give only steroids because the diagnosis is very clear from the pathology, and we don't have immunological data referring to vasculitis or lupus or whatever. It is IgA nephropathy only. rapid progressive in nature. So the steroid is what we had, because the immune suppressive treatment, the traditional immune suppressive treatment for IgA are frustrating, but the majority of physicians and nephrologists treat with steroid for these cases. So I agree with you 100%. Dr. Riyad, if you allow us to have 10 minutes for comments from the audience and the professor, because we have today the gathering of very experts from everywhere. So anyone who wants to chair, just raise hand. Dr. Mohammed Saeed, in 1 minute only for everyone, please. Dr. Mohammed Saeed.
Yeah, thank you for the elegant case. And I think this patient might have chronic IgA for a long time, for the last 5 years, and the hypertension might be secondary to the chronic IgA from before. The other comment, I think the antihypertensive treatment should be modified after we improve the creatinine to S&R, which is the first line of treatment. The treatment cyclophosphamide steroid is highly controversial, and we cannot confirm or reject the use of cyclophosphamide if it will be used cautiously. But there is certain report about combining steroid and cyclophosphamide.
Thank you very much, Dr. Mohammed. Thank you. I think Dr. Magdi Sharqawi.
وينك يا مجدي؟
تسيم من عنده مشكلة. دكتور فيصل شاهين.
Yes, thank you, Prof. Hussein, Riyad, Mohsen. Thanks for this good case and nice case, and also the teaching one. And I agree with Mohsen that probably cyclophosphamide we have to not to give it. In such case, we give steroid and wait and see. And still, also I agree that. Sorry for that, because maybe I have interruption in my telephone. But I agree that such case could have existing IgA for a long time. That's why the basic creatinine doesn't come down to normal. It is still 2.1 milligram per deciliter, as I can see in the slide. So probably it is a long-standing IgA, have CKD stage 2 or 3, and the steroid may can affect it to have the acute insult which happened to it. That's from my side. Thank you.
Thank you very much, Professor Faisal. Here there is a question in the chat about plasma exchange in IgA. And yes, has no rule. It has no rule. Yes. Dr. Yasser Al-Mulla can share with us, and he'll be me, Muhammad. Yes, unmute Dr. Yasser.
Excellent case, and to be honest أنا لست حتى طويل بعلم أمام العمالقة هنا لكن I would personally plasma exchange this patient. I do fully agree that there is no strong evidence for plasma exchange, but if we're going to talk about evidence in nephrology, there is no evidence for most of what we are doing at the moment. And to be honest, probably if you compare cyclophosphamide versus plasma exchange, probably I would say the plasma exchange here is less harmful compared to the cyclophosphamide. But given his age and given the acuity of the case, I think I will go and proceed with the plasma exchange. Prof. David Jane from the UK, who's an international figure, and Prof. Liz Lightstone will always plasma exchange those patients. But again, I agree on the slide that was mentioned by Prof. Riyad that there is no evidence for the plasma exchange. It's just that he's young, and I'll try my best. And I would be grateful if I know what would be the practice of others and whether anyone else would be keen to plasma exchange this patient or not.
I think it is a very rational comment. Dr. Elkossi?
Just only I would like to say that probably the response here is mainly because of the steroids. I don't know, it is a speculation. But I don't think that the cyclophosphamide or the plasma exchange could be supported by any evidence in these circumstances to just put the patient for the plasma exchange to clear what for how long. We are not, in the literature, I can't see that the plasma exchange is, supportive in these circumstances, to be honest, of the crescentic or rapidly progressive forms of IgA nephropathy. It is the steroids, try it and see how it goes. And as all the comments came back to say that the residual kidney function, probably the patient rightly said, it has been for quite some time, he has got chronic kidney disease. Particularly, we don't have any figure about his baseline creatinine. It's 2.1. Might be this is the baseline creatinine or slightly lower than that. So
allow me, Hussein.
Yes, please.
I reviewed the literature last year when we talk about plasmapheresis in GN. Basically, definitely, I will not really do plasmapheresis for a patient with IgA nephropathy.
Yes.
Okay. Now back to the cyclophosphamide. It has been done. It has been written, but not really on a large scale. And the patient received initially 1 dose IV. And then, as you notice on the screen, he was given oral cyclophosphamide, 100 milligram for basically a period of 3 months. Now, whether it's contributing or not, but we agree steroid is the cornerstone of therapy.
And if it is a case of IgA plus positive ANCA, for example, here this is completely different, and the plasma exchange, yes, plasma exchange may be given for this case, and the cyclophosphamide, I think if there is ANCA or antibody, yes. Dr. Saeed Khamis, last comment about this case.
Thanks, Professor Riyad, for this elegant case. Just before the step of the biopsy already the gold standard and already solved the problem. But before this, I know that your excellent way of teaching to broaden the differential diagnosis, why not we didn't do this fundus examination, number 1. Number 2, blood film to see schistocytes is there. Despite I know that platelet is okay and the hemoglobin is okay, but just for teaching purpose, why we didn't broaden the differential diagnosis to rule out or in this TMA? Thank you.
Well, let me tell you, there was no indication really for HUSTTB fragmented cells. Okay, there is no evidence of anemia or evidence of that. That's one thing. Fundoscopic examination, I'm sure it's being done, okay, not on a routine basis, but doesn't really much going to contribute the grading of the hypertensive issues. I agree, it should be done on any hypertensive patient. That's really not the purpose of this pathology conference, but yes, your word is well taken.
Regarding the point of Professor Saeed, yes, biopsy here is extremely indicated because we have acute renal failure plus nephrotic and nephritic. So biopsy is indicated even if there is from lab, there is a cause like lupus or vasculitis, biopsy is extremely indicated to guide us for therapy.
Okay. Can we move to the second case?
Yes, please.
Okay, the second case here, we have a patient who again with acute kidney injury, long-standing history, non-productive cough, and shortness of breath. Let's go through that. He's basically a 53-year-old gentleman, impaired kidney function. He was seen and we consulted on because of, again, mild hypercalcemia. He has history of chronic non-productive cough for the last 12 months and more recently general fatigue and exertional dyspnea, but no hemoptysis. He has nocturia 2 to 3 times per night for the last 6 months. History of well-controlled hypertension for the last couple of years. There was no history of diabetes, hematuria, stone formation. He's an ex-smoker. When he came to us, his medication, amlodipine, 5 milligrams twice daily, different courses of antibiotics for chest infection, and he denies any history of non-steroidal intake. He's 65 kilos, normotensive, mildly dehydrated when he came to us. Chest examination was no deformity, good air entry with occasional wheeze. Cardiac exam, abdominal exam, normal, no peripheral edema, peripheral pulsations were intact. His findings, urine analysis, we start always 1+ protein, few RBCs, white cells 40 to 50, no cast, and his culture was negative. Spot urine protein creatinine was around 400 milligram, so mild amount of proteinuria. His hemoglobin, he's a smoker, was 13.5 gram, white count good, platelets, PT. Serum test, creatinine 2.8 milligram per deciliter, total protein 2.7, albumin is good. His calcium 12.8 11.12 milligram per deciliter, phosphorus 4.7, and his parathyroid hormone is 25. Our normal lab is up to 55. So his serology, all has been done. Procedure profile negative, hepatitis B, C, normal C3, normal C4, ANA normal. His ESR was 20/75. Ultrasound, sonography, normal size kidneys, chest X-ray, prominent hilar regions. Unfortunately, I don't locate, because it's an old case, I'd not really locate his chest X-ray. So we have a patient here, high calcium, impaired kidney function, chronic productive, non-productive cough, and occasional wheeze. With high ESR normal, everything is normal. Mild proteinuria and mild hematuria. What will be our likely diagnosis? Clinical comment.
Dr. Elkossi.
Right, okay. I will just direct myself to our two common, not common, obviously, I mean, with this presenting history about the sarcoidosis and about the multiple myeloma. So I would like to know the serum electrophoresis before we proceed, and probably the ACE level, although the ACE level is not, I mean, confirmatory in these circumstances with the impaired kidney function. So have we got these ones, and look into the chest X-ray as well to give us an idea whether there is any suggestion of the sarcoidosis?
The chest X-ray, really just what I have, the report of that prominent hilar region. There was no lymphadenopathy apparent on that X-ray.
Okay. So, and the serum electrophoresis, I presume was?
I'd not do it. I'll tell you why.
Okay.
Okay. You asked about something else.
Maybe the, again, the eosinophils were normal?
Yes.
Eosinophils were normal. CT scan, maybe.
Now you asked something else before.
Yes, high resolution CT probably.
In addition to kidney biopsy, what else you'd like to know? And you mentioned ACE.
Yeah.
Here is the ACE.
Yeah. Again, it is elevated, but with the impaired kidney function, I'm not entirely sure, but it is again something to direct myself toward the sarcoidosis. And that's why I'm asking about the high resolution CT, whether there is any high resolution CT of the chest to see.
No, I don't have it.
In the chat, there is the point about vitamin D. Dr. Elkossi, do you like to know the vitamin D or active vitamin D level in this case?
I don't think that it will help that much in the diagnosis of this case, to be honest, with the creatinine of 2 point something.
Okay. So,
and I think another point in the lab, total protein is not so high. So albumin is 3.8 and the total protein is 7.2.
Yes.
So I think this is why
again, still, it is not against, I mean, it's still not against, I mean, a case with impaired kidney function, with hypercalcemia in his age group. I still would be interested to know the serum electrophoresis before I go with the kidney biopsy. Or
even with normal hemoglobin, 13 point something?
Maybe. Because that easy test rather than going for the biopsy straight away. Anyway.
Yeah, carry on. But anyway, you know, this is a pathology conference. I'm sure we're going for the kidney biopsy.
Yes, please.
Otherwise, we're not presenting the case. Okay, now here is the, our differential was sarcoid with acute renal injury. Our differential most likely, as you mentioned, Dr. Mohsen. Now, hypercalcemia could be the cause, could be granular interstitial nephritis, could be sarcoid-related GM, but we have very few RBCs, we have very little amount of protein. So really between the hypercalcemia as a cause of his acute kidney injury or deterioration or interstitial infiltrate. Now, how we differentiate between both?
Dr. Fuad writes on the chat that you may have the results of biopsy faster than serum protein electrophoresis. If this is the reason for postponing serum electrophoresis?
Not really, no. In this patient, we didn't do it. Yes. In this patient, yes, our kidney biopsy.
But it is needed.
Today, next morning, we have it. If we deliver this specimen before 2 o'clock, by 10 o'clock next morning, we have our light microscopy with all 4 stains, including Kappa and Lambda. And then by 2 o'clock, we have our immune fluorescence study available.
Very nice.
That's the quickest thing you can have. Okay. How we differentiate between granulomatous interstitial nephritis and sarcoid? Basically, RBCs, hematuria, proteinuria, and others. Now, urine analysis, here we have very small amount of protein, and spot protein, RBC is not really this. Are you impressed with the white count with the sterile pyuria?
Yes. Dr. Elkossi.
White and sterile pyuria.
Sterile, but again, this is another, I mean, issue about this probably granulomatous, yes, granulomatous interstitial.
Okay, so that's all that in favor of what you mentioned, most likely sarcoid-related diseases. And then we have the biopsy here. We have 14 glomeruli seen in the light microscopy, and we have 9 glomeruli available for the immune fluorescence studies. Dr. Wesam, the floor is yours.
Yes, Dr. Hussein.
Okay, thank you, Dr. Riyad. Again, this is an H&E stain, and as you can see, we have 2 cores and very low power, but seems that there is also a significant chronic interstitial damage. Yes, can we have the second one, please?
Yes.
Here seems that there is the glomeruli. There seems to be some segmental soft sclerosis here. But then we have also significant interstitial fibrosis and some aggregates here, some lymphocytic aggregates. Okay. I can't see clearly. Is this a joint cell? I don't really, and yes, and here also seems to be another joint cell, if I'm right. Do you have a higher power on these?
Yes, I'm going through.
Yes, okay. So this is just an ischemic glomerulus. There is nothing in it. There is periglomerular fibrosis and slightly shrunken tuft, but otherwise it's more or less unremarkable.
What about the eosinophils, Wesam?
Yes, there is
abundant
eosinophils in the infiltrate. Yes. As well as plasma cells as well.
Yes. Again,
another slightly ischemic glomerulus and interstitial infiltration. Here, there is no significant eosinophils within this shot.
This area. That's the PES.
Yes, and just in this area. That's the PES, and it shows you that there is nothing wrong with the glomeruli. That's the globally sclerosed glomerulus, and that's more or less a normal glomerulus. But again, you have an interstitial infiltrate with eosinophils. Okay, yes. Again, interstitial nephritis with eosinophils. And yes, I would like to have a high power on this area, if we can, because it seems there is something here.
You have it.
Yes, thank you. This is a joint cell. This is one joint cell which pathologists call like Langhans joint cells, because all the nuclei are arranged to one side. This is another joint cell, such a regular joint cell, because you have all the nuclei scattered all through the joint cell. And probably these are some epithelioid cells. I don't see frank necrosis actually, but this is definitely a joint cell granuloma. And here, so these are asteroid bodies. So this is like foreign body joint cells engulfing these bodies, which are more likely to be with sarcoidosis.
That's what we call Schumann's bodies. Schumann's bodies.
Schumann's bodies, yes, or asteroid, yes. Again, another granuloma. This is a trichrome stain, I think. And yes, you can see another granuloma and the joint cells here. These are joint cells as well. So this is a granulomatous tubulointerstitial nephritis, most probably compatible with sarcoidosis. Of course, the presence of the Schumann bodies really helps.
What is the specificity of Schumann bodies, Dr. Wesam?
They're not really specific, but they've been described only with sarcoidosis. At the end of the day, this is a foreign body joint cell engulfing some calcified material. But due to hypercalcemia and calcification gets engulfed by the joint cell, so it's more common to see it with sarcoidosis. So if you have a granulomatous interstitial nephritis and you've got this, then the balance is tipped towards sarcoid, of course.
The problem is in granulomatous interstitial nephritis, you may have hypercalcemia. And then
yes, hypercalcemia is non-specific.
Yes, non-specific, and granulous interstitial nephritis is not specific for sarcoidosis. If we don't have hilar lymphadenopathy and even ACE level is not specific, and I'm eager to hear from Professor Elkossi after the lead of
Yeah,
Professor
as
Riyad.
we've discussed before, with
Yes.
the granulomatous tubulointerstitial nephritis, sarcoidosis is a diagnosis of exclusion.
Yes.
So
Dr. Riyad.
after you've excluded
Yes.
the common causes, and then sarcoid would be a diagnosis of exclusion. And sarcoid can never come as an isolated kidney disease. But I think this patient had a wheezy chest also, right?
Cough.
So he did
cough,
have
yes.
some form of pulmonary affection. Otherwise, I would be very reluctant with the diagnosis.
This is why Professor
But here
Elkossi
it seems more or less straightforward. Yeah.
This is why Professor Elkossi asked about CT scan of the chest. Professor Elkossi.
True.
Yeah, I mean, obviously the granulomatous tubulointerstitial nephritis could be drug-induced, could be anything else, but it is high likely to be the sarcoidosis. If we have got the CT scan, high-resolution CT, will give us more idea or more insight whether the chest is involved with a sarcoidosis picture or not. The ACE level with the impaired kidney function still is not diagnostic, obviously, but it is elevated ACE level can again point toward the sarcoidosis. But in any case, whether it's drug-induced or it is sarcoidosis, the treatment for both, Dr. Said will tell us now, will be the same unless there is an offending drug, you need to take it off.
Okay, Professor Riyad.
Let's move on.
Yes,
so
please.
really, as we have most likely, this is non-granular, system, by the way, was done. As you see here, 14 glomeruli, non-caseating. We have it was negative for FB, that it's a must, should be done all the time. And we have the immune fluorescence here, it's all negative. So we said this is most likely sarcoid interstitial nephritis. Now, if you look how we managed really this patient, and I'll go to, we managed his hypercalcemia shortly by hydration. And then for the findings of this, we gave him steroid therapy, basically is the cornerstone of management for patient with sarcoid. And we controlled his blood pressure, and his proteinuria 2 weeks later came down from 400 to 150. Creatinine came down from 2 something to 1.5, and calcium controlled, hemoglobin is fine. His ACE level and ESR, by the way, that was 75, it came down to 11, and his ACE level from 85 came down to 35. His prednisone gradually being tapered, and he stayed for 20 to 30 milligram daily for 6 months, basically for his lung disease, based on the recommendation of the pulmonologist. Now, sarcoid, I'd like just to see, this is x-rays that we have from the teaching files, looking about how it really happened with sarcoid. We are not the expert, but it's nice, you know, to show this, and also the high resolution CT scan that I don't have. One thing, renal disease in sarcoid, mostly calcium related, stone related, and then you have the granulomatous, and very few patients with occasional glomerular disease, urinary tract obstruction, and some of them, they will have end-stage kidney disease. I'm impressed with not every glomerulomatous disease is sarcoid. There is a nice study, I'll go through here. Renal granulomatosis in Baltimore study, journal 2007, 40 cases of renal granulomatosis, 20 of them were sarcoid. The remainder were drug-induced, as we heard, it can, TB, Wagner, by the way, leprosy, Mycobacterium avium, and Crohn's disease. Okay, it can happen. And if we are lucky, if the patient will come sometimes with uveitis, which is not uncommon, they will have what we call tenure. So part of the differential diagnosis that will be here. Dr. Elkossi, what do you think about this now? Are we having sarcoid mostly or something else? Especially, I'm impressed with the eosinophils that we have in the specimen with the granuloma. Could be again drug-induced.
To be honest, could be drug-induced, but we don't have any offending drug to blame. More important than that, you have got the chest X-ray suggestive of hilar enlargement. So ACE level is elevated. So I would go for the sarcoidosis. And even if it is drug-induced, as I mentioned, the treatment of both will be the same, except for the drug-induced, you need to remove the offending drug if you know what's the offending drug for the granulomatous tubulointerstitial nephritis. The most important thing, it is not Wagner's, obviously. It is not infection like TB or leprosy. So I will just go for, as it is, sarcoidosis. And I mean, he responded very well to the steroid treatment.
I think chest X-ray here. Yes, I agree with you, Professor Riyad. It is a case of sarcoidosis because chest X-ray is impressive. There is hilar congestion or lymphadenopathy, and there is interstitial lung disease. And if I expect if CT was done, you will find interstitial lung disease as well. So it is sarcoidosis, hypercalcemia, granulomatous interstitial nephritis, lung affection. I think this is the triad that make the diagnosis in sarcoidosis in confidence. So I agree with the diagnosis. But to put in mind, the most common cause of granulomatous interstitial nephritis is drugs. And the drug may be unknown or maybe remote drugs. So to put in mind. This is my point.
One point again, glomerular diseases, in addition to sarcoid,
yes,
you can see anything, ranging from membranous, IgA, minimal change, proliferative with crescents, ANCA positive sometimes, focal, and that's the clue for that will be heavy proteinuria and red cell cast, and something that we don't have in this patient. So it's very unlikely to be glomerular disease. We know it is interstitial process. That's what we have.
The question to Professor Elkossi, if we treat with a steroid and there is no response, do you like to add adjuvant treatment or other immune suppressive drugs? Because it is reported, yes.
I don't know the evidence for that. I mean, but we usually use, as you know, the adjuvant therapy like azathioprine or anything else is just as a steroid sparing rather than anything else. So it is the steroid, and if it didn't respond to the steroids, I don't know the answer.
Professor Riyad, do you like to?
I don't think that there are one, if it is part of TMU,
yes,
okay, then methotrexate will be the drug of choice, will be a drug to be added again.
Okay. We had a case with some similarity of this scenario, but in the era of Corona, we opted not to use any adjuvant treatment to give short steroid course for the patients. So Corona to put in mind again and again until it is finished.
Hopefully.
Hopefully
soon.
We hope to celebrate the vanish of Corona. I prefer to have 5 minutes only to have comments from the floor. Dr. Mohammed Saeed, 1 minute. Sorry, unmute yourself, please.
I agree with Professor Riyad that is a case of sarcoidosis. But what I would like to mention that most of these cases usually diagnosed by extrarenal manifestation.
Yes, this is what we. This
what I think. Yes. Yeah, the CT was mandatory in this case because if the other way around, if we notice sarcoid and we give treatment and the steroid and the calcium came back normal and the creatinine normalized, I don't think there was an indication for renal biopsy because the patient was at that time was diagnosed fully as sarcoid. We don't usually commonly see patients diagnosed by renal biopsy. Usually they diagnosed by extrarenal and CT. So I think, in my opinion, it was mandatory pre-biopsy.
But in this case, it was not only renal impairment and hypercalcemia. There was also proteinuria. So I think biopsy.
400.
Yeah.
400. It is 400, very minimal.
Okay, Dr. Riyad.
Well, but you have creatinine in something, and there are some clues that we are dealing with some element of renal disease, tubular disease, negative culture, sterile pyuria.
Sterile pyuria, yes.
Interstitial nephritis.
Really, maybe our margin of doing kidney biopsy, we are more liberal, and I wish that everybody will do more liberal. That's how we learn. That's how we really learn a lot about nephrology.
In this case, it's not a liberal to do biopsy. It is indicated because we have acute renal failure and sterile pyuria and this mild degree of proteinuria. So we know it is mostly acute interstitial nephritis. Biopsy is needed to get us for treatment. and I think this is a standard.
Very
of
nice
care.
case. A very nice
Yeah.
case.
Okay, if there is any wants to add, or we can move to the next case, Dr. Riyad.
Okay, I think
Okay.
this will be more challenging.
Yes,
And here, okay. Now, a 55-year-old gentleman admitted to our hospital, evaluation moderate renal functional impairment and severe anemia. 6 months earlier, history of back pain and progressive fatigue with frequent use of painkillers. 2 months prior to admission, he noticed swelling of both lower extremities and difficulty in urination with nocturia 2 to 3 times. He was told to have impaired kidney function for the first time, no diabetes or hypertension. He's a middle-aged, his blood pressure is good, he was dry and wasted, both temples with no lymphadenopathy, both chest and cardiac examination normal, abdominal exam showed mild splenomegaly, otherwise normal. By the way, he was under the care of a hematologist and we were consulted later. 2+ lower lymphedema with intact peripheral pulsations, severe tenderness over the lumbosacral spine, and his gait was extremely difficult to walk because of that. His hemoglobin was 6.5 gram. Platelets 165,000, ESR 118. Serum creatinine 4.6 gram per deciliter. And urea bicarbonate, he was acidotic. Calcium 9, phosphorus 6.3, total protein 6.8 with albumin 2.9. Sugar is normal, uric acid is up, liver enzymes normal. So anemia, high ESR, and abnormal kidney function. Urine analysis showed few white cells, few RBCs, and 1+ protein, but protein creatinine ratio 7.5 gram. Serology, hepatitis B, C, ANA, ANCA all were negative, and his parathyroid hormone was 35. I highlighted for you the protein in the urine and the dipstick findings. So, a 58-year-old gentleman, 6 months history of back pain, progressive fatigue, anemia, abnormal kidney function, proteinuria, in absence of basically 1 trace protein by dipstick. What's our differential diagnosis?
Dr. Mohsen?
I believe that I would like to know about this patient's serum electrophoresis and what is the background from the hematology. So what are the hematology is treating for? Has he had any also X-rays at all for osteolytic lesions or anything like this?
He wasn't treated at that point in time, just he came in and they found this and they consulted us. So basically he came to us and we saw him on the same day as the hematologist when he saw him.
Okay.
So this is a fresh case. I'm presenting it as we saw this patient. We're going to work together what we did to this patient.
I see.
So the majority in chat saying multiple myeloma, plasma cell dyscrasis, so back pain, anemia, and renal failure.
Well,
so, debestic minimal proteinuria that is very nephrotic, so it is all these are close for myeloma.
Yeah, I agree, myeloma or plasma cell dyscrasia,
yes.
But to me, it more really than just the classic myeloma that
yes.
we are dealing with, because when the dipstick is negative or 1+ and we see heavy proteinuria, I'd like to think about light chain, what we are seeing, something like Benz-Jones proteinuria, light chain myeloma.
Yes.
Agree, Dr. Elkossi?
Okay, yeah. That's why I'm saying about the serum electrophoresis or any osteolytic lesion with the X-ray.
Okay, I'll show you now what we have. So
and in the chat there is also another differential diagnosis, non-steroidal abuse.
That's
complicated by minimal change. But if it is like this,
minimal
I think
change,
proteinuria will be detected. Yes.
Will not give you 1+ protein.
Yes. Debestic
3-4+.
Debestic is close here against minimal change.
And why the hemoglobin is 6.5?
Yes.
We're going to see now.
Okay.
Now, serum protein electrophoresis, Dr. Elkossi asked about, and this is a serum protein electrophoresis.
Yes, it is non-specific.
What do you think?
Can you explain, please, to the floor about
that's the albumin,
yes.
alpha 1, alpha 2, beta, and this is the gamma region.
It is negative for myeloma, but it's not enough because we know that there is fallacies in serum electrophoresis, so we need immune fixation, I think so. and it's free light chain. So the triple lab, electrophoresis, immune fixation, and light chain, free light chain.
Yeah.
So to me here, you know, there is most likely, if we don't see anything in the gamma region,
yes, it is
represents some element of light chain, that all of it being secreted in the urine, and that's what you requested here, 24-hour collection for immunofixation, and that's what we have. IgG kappa monoclonal band and 24-hour here kappa lambda was 2.3. That's by immunofixation. Now, what do you think, Dr. Hussein?
It is abnormal to me with this impaired kidney function. So it would be better, to be honest, for the serum as well, to see the free light chain in the serum. So I'm not sure about the serum. And if there is any X-ray has been done to the patient, that would be great to know.
Okay. There's the skull X-ray.
Okay. Yes, you can see you have
two lytic lesions.
Yes,
yeah.
you pointed yourself.
Very classic.
Explanatory. You know, that's punched lesion, multiple clear punched lesions all over the skull. And that's really, you know, what we'd like to see always in a patient with myeloma.
Yeah.
So I think this is the X-ray. Now,
so if you allow me, excuse me, yes. If you allow me, Professor Riyad here, because in the chat there is some comment about bone scan. If I put myeloma in mind, it is not bone scan, because
I don't do bone scan.
Yeah, it is not indicated because it is non-specific, and we will not find any osteosclerotic lesion by bone scan. So if we would like to do any radiology, it is skeletal survey, like a skull X-ray here in this case, not bone scan.
For the osteolytic lesion, yeah.
Yes, yes.
Then we proceeded for bone marrow. The hematologist did the bone marrow. Dr. Wesam, now you are our pathologist.
For the bone marrow as well, and I know. Okay, now as you can see, this is a hypercellular bone marrow, and this.
Okay.
Bone marrow, but
yes.
Usually you get more fat cells than so you get more or less the inflammatory cells, or the lineage, not the inflammatory cells, the bone marrow cells, together with more fat cells. So we have minimal fat here. So this is the hypercellular marrow to start
higher
with.
Power.
And then the second one, yes, the higher power. And of course, you can see all of these seems like plasma cells. Of course, the erythroid precursors, also the erythroblasts, do look like plasma cells as well. But this, to my eye, look like also plasma cells. This is definitely a plasma. This is definitely a plasma. This might be an erythroid, an erythroblast, but the rest are all plasma cells. And for the floor and for everybody else, again, this is another high power. And you can see that there is also, these are all plasma cells. So it seems like a plasma cell dominant infiltrate. And what we do is that we calculate the percentage of plasma cells in relation to the rest of the cellularity. However, because we know now that even more than 5% plasma cell infiltrate with an end organ involvement would be also diagnosed as myeloma, and 5% is really a small number. So it's always helpful now to always do immunophenotyping on bone marrow, especially for CD38 or 138, to properly detect the percentage of plasma cells which are present. But this, if they are up to 40 or 30 or 40%, what's above that is usually clear on light microscopy.
Okay, so
it seems like a plasma cell.
Yes, the summary of the case now, we have a patient, nearly 6-month history, back pain, progressive fatigue, he's profoundly anemic, high ESR, destructive bone lesions, abnormal serum protein, heavy proteinuria, dipstick, and bone marrow is diagnostic of plasma cell. Now, what our next step? I think we are a nephrologist. We'd like to have a kidney biopsy. We have 18 glomeruli on the light microscopy and 7 on the immune fluorescence. Now, Dr.
Just
Wesam,
before we see the biopsy, yes, before I comment on the biopsy, because this is a regular debate and it's already a question on the chat. Is there any need for renal biopsy? Now, that's a question which is always asked.
This is
So
why
you know that the patient,
Dr. Wesam,
you know that the patient is myeloma. Yes.
this is why I asked Professor Riyad about the serum free light chain. Because if I know the case is myeloma and there is acute renal failure, sure the diagnosis is myeloma and there is acute renal failure, I'm going to do biopsy if serum free light chain is lower than, I think, the cutoff point. I forget the cut point, but I think it is 500. If you correct me, Professor Elkossi, I'm not sure of the figure. So if serum free light chain is very high, this is myeloma cast kidney, and we don't need biopsy of the kidney.
What about the proteinuria, the 7.5 grams?
To be honest, I mean,
Yes.
there is a very interesting review about the indication of the biopsy in the multiple myeloma and the NDT.
Yes.
And they suggest that from the hematology perspective and from the renal perspective, that in many cases of multiple myeloma, and they have just highlighted the indications of the biopsy in the multiple myeloma in this article, that it can give you some more insight on what is going on in terms of the prognosis as a prognostic indicator for what is this myeloma is going to behave in the future. Not only because of the kidney only, it is because also of the multiple myeloma.
But for
exactly, this is the whole point of the biopsy, that the different lesions, which can be caused, different renal diseases, which can be caused by multiple myeloma, has different prognosis. And this is very important for the hematological management and for the renal prognosis. So we know the diagnosis, but you need to know the prognosis of your patient. And this hence the importance of the biopsy. The biopsy here might not be diagnostic as per that you need to know that the patient is myeloma and probably has a light chain disease, but it's diagnostic in the form that you know which light chain disease you have and the extent of renal damage you have. And according also, because hematologists manage differently, and the perspective of bone marrow transplantation as well as also differs according to the renal lesion. So the renal histology is very important for the hematological manifestation and for the nephrologist to know the prognosis of the patient. Last comment, someone on the chat.
So Dr. Riyad, do you agree for routine biopsy of patients with?
Routine biopsy on any patient with myeloma. We are really more liberal, and that's really how we are gaining our expertise in all nephrology and renal pathology. So it's basically we perform 2 to 3 or sometimes 4 kidney biopsies a week in our private hospital, and the results are really, in fact, we presented one time what we have, and we are looking really more to look and see where we start. But yes, I'll biopsy a patient, every patient with myeloma, with the help of the hematologist. So, again, they require, in order to help them, guide them concerning therapy and outcome assurance for the patient.
Okay, but,
yes,
but I have some debate in this point, but I'm going to stop, Dr. Wesam. Okay.
Yes, because they also, following your debate, Dr. Hussein, they say that if more than 1,000, mostly cause nephropathy, yes. But if you have cause nephropathy and amyloidosis, if you have cause nephropathy and MIBD, then if you have cause nephropathy and light chain proximal tubulopathy, this will change the management of the patient, the treatment of the patient. So you really need to know the morphology. Okay. So yes, only the last comment on the chat, someone said MGRS. No, this cannot be MGRS because the patient has frank myeloma. MGRS is when you have a negative bone marrow and a positive serology and organ involvement. But since the bone marrow is positive, so this is a myeloma and this cannot be classified as MGRS. Okay, we can see the biopsy.
Okay, now here is the biopsy, Wesam.
Okay, again, we have 2 cores, it seems 2 good cores of renal cortical tissue and a lot of glomeruli, and this is again a low power H&E stains, but seems there is something going on with the glomeruli. Yes, there is definitely something going on with the glomeruli, even on this power and an H&E stain. You can see that you have these hypocellular mesangial nodules here. Again, this glomerulus has 1, 2, 3, 4. This glomerulus has a lot of hypocellular nodules. Classic nodular glomerulosclerosis, which you see in diabetes, but this patient is not diabetic. Again, here, this is nodule. You have nodular sclerosis. So this is what we call nodular glomerulosclerosis, and has the differential diagnosis of diabetes, since this is the commonest, followed by light chain disease, then other types of deposits like fibrillary GN and so on, and of course amyloidosis. But now you have all of these hypocellular nodules and slightly thickened GBM. Also seems that the tubules have thickened tubular basement membranes here. Can we have another one, Riyad?
Another one? Same?
Yes, another one is, yes, it's more or less the same pathology.
Same findings? Look
Same
about
findings. Yeah, see, oh, a large nodule, variable size nodules, and the PES. Okay, even when you see a PES with such strong PES positivity for the mesangial nodule, we automatically exclude amyloid. Of course, we do Congo red, but then again, Congo red doesn't give you such strong positive PES stain, and you can see that the tubular basement membranes are also thickened and wrinkled. Again, the change you can see in diabetes along with light chain disease.
Wesam, you'd like to comment about the staining of Bowman's capsule and how strong it is?
Yes,
and
the Bowman's capsule, yes, or as well, yes.
The tubular basement membrane, it's how strong?
Yeah.
Mm-hmm.
Yes, and then I said that the tubular basement membranes are strongly PES positive as well, and they're thickened, they're remarkably thickened. Compare it to the tubule below it. Again, the glomerulus, and you can see the mesangial expansion and the nodular sclerosis. Okay, I think the next one is an immuno one.
Yes, and then we have the immunohistochemistry, and this is kappa.
Kappa?
Yes.
Yes. Okay, now an important point, although that these lesions are basically mesangial and nodular sclerosis, the positivity is on the glomerular basement membrane. So you need to see the kappa deposits, like in this very nice stain, along the glomerular basement membranes and not in. This is what not. So as you can see, you have diffuse kappa staining along the glomerular basement membranes, slightly in the Bowman's capsules, and should be on the tubular basement membranes as well as here. So you do get some non-specific mesangial staining, but the diagnostic one is on the glomerular basement membrane. Okay, do we have another picture? Yeah, again, as you can see, the mesangial nodules has a much less intensity in staining because we are actually not what we're targeting here, but you can see very nice kappa staining along the glomerular basement membrane.
Really well,
and along the tubular basement membranes as
and
well.
also the tubules. That's kappa.
Oh, yes.
This is lambda.
Yes, that's kappa.
Yes. There is a great difference.
And lambda is completely negative, as you can see. Yeah.
So what do you think, Wesam?
This is a negative immunohistochemistry because you don't get this specific brown stain. So in immunohistochemistry or in immunoperoxidase, this is what you get. You get this blue background with a positive brown staining. If yes, you can compare the first pictures we've seen with a strong kappa brown staining. Yes, like this one. So you see this nice brown staining here. This is positive, while here you get no brown staining at all, or red-brown staining, depending on the counter stain you use. With here, it's totally blue. So this is a negative immunoperoxidase or immunohistochemistry stain. Okay. So lambda
kappa,
is negative.
yes.
Kappa is the 3+. This is definitely light chain monoclonal immunoglobulin deposition disease, MIDD, kappa type, nodular glomerulosclerosis.
By the way, Congo red stain for amyloid was negative. We do it routinely.
It doesn't look like amyloidosis.
We do it routinely on our lab. Congo red is part of the regular staining for our biopsies.
Do you need EM, Dr. Wesam? In this case? For me, it is not needed because it is the diagnosis is clear. Kappa, intense kappa with negative lambda. It's okay. It is light chain as a part of myeloma. So it is
This is
myeloma.
an immunodiagnosis.
Yes.
Because even so, what if you have EM? Then you can see that it's light chain. You need to know which type of light chain it is. So no, EM is only an addition here. You don't need it.
Addition.
It's not even.
Yes.
It's not even to confirm the diagnosis. The diagnosis is done by the light microscopy and by the immuno. This is one of the diseases which is an immunodiagnosis.
And in doubt, it may be clarified by EM, but here it is clear. Kappa, intense kappa, negative lambda.
I don't know how in doubt you can clarify it by EM actually. I mean, if you have light chains, then they need to stain for kappa or lambda. Maybe if you get both stains negative and you have evidence of myeloma, which can happen because sometimes you cannot detect properly the light chains in tissue, because if they are mutated or if they truncated, then the EM would be required to tell you that you do have light chain deposits within the kidney.
Okay,
but
here
again, it's not going to tell you which type of light chain. But for this case,
we don't need at all EM here. Dr. Elkossi,
okay.
Do you like to know?
And it did not turn to be a cause nephropathy at the end of the day.
It is light chain as part of myeloma. Dr. Elkossi.
I totally agree with what has been said about the case. I'm not entirely sure about the immunoperoxidase or the histochemistry staining or immunofluorescence, what is the best in these circumstances, or might be depending on what is available in the lab. Again, there is some sort of what we call it pronase digested paraffin sections. If it is not available, maybe Dr. Wesam can tell us if this is something. If it is not available, be right to go to the EM. I don't know. This is something histopathologically pure rather than anything to do.
No, yes. Well, the pronase digested paraffin section is to allow you to perform immunofluorescence techniques on paraffin embedded tissue. It usually doesn't work well worldwide. It's not always helpful. What would be helpful actually is in situ hybridization, and this is done with the immunoperoxidase technique, not with the fluorescence. Or some labs do fish and others do fish for kappa and lambda. So we do in situ hybridization on the biopsy, but then this will definitely get you a conclusive result. But for pronase digestion, usually the technique is not very well tolerated. Sometimes it works well, others it doesn't. I know of one lab in India where they say that they use it routinely, Jessica Singh, and she says she uses it routinely and it works well, but this is as far as everybody else is concerned. Even Agnes Fogel says sometimes, I know a lot of pathologists like Ian Roberts in England and others, no, it just doesn't work. We've tried it as well and it just doesn't work. Its validation is difficult.
So I think the best practical point that we learned from Professor Wesam during her course of nephropathology is to have a core for AM. If we need it, to go ahead for AM and to avoid needing to repeat the biopsy. This is the most important point.
I think exactly what we are doing, Dr. Hussein.
Okay.
We have the specimens available all the time. We stored it, and if we need it, we'll send it after that.
Perfect.
But we don't send it routinely.
Yes.
Now, I hear Dr. Elkossi mentioned about immunohistochemistry or immune fluorescence, which is best of the two. Really, we have both in our place, and it seems to be routinely we do now immune fluorescence for kappa and lambda. If we don't do it, and for example, retrospectively, we'd like to look for kappa and lambda, we can do it by immunohistochemistry on paraffin block. That's the difference. We can do it on the paraffin block, which is quite easy.
Dr. Riyad Bey, Dr. Saeed Al-Ghamdi, I'd like to hear from you. Dr. Al-Ghamdi.
Assalamu alaikum wa rahmatullahi wa
barakatuh.
As usual, Professor Riyad Saeed is really striking us with those wonderful cases. Thank you, Sam, also for this very, as usual, it's nothing new from Wesam and from Professor Riyad Saeed. Actually, just I'm asking Professor Riyad Saeed, if you look at, for example, previous studies coming from Saudi Arabia, 1996, Professor Mutwalli has published his GN registry from Riyadh region and published in the American Journal of Kidney Disease. And despite that large number of cases was published, no single case of this plasma cell discrasis or from myeloma and others. It was considered a rarity. Right now, actually, every week we do, I mean, not every month we get some diagnosis of paraproteinemia and some sort of plasma cell discrasis. Your explanation, do you think this is actually just missed cases, or just we are changing with the Gulf War, and what's in your mind, Professor?
I don't know, really
Thank
here,
you.
by the way, we diagnose most of our cases, we diagnose as nephrologists, and then we send them to the hematologist. We see, in this week, for example, we have 2 cases in our hospital, and we have biopsies on them. I'll say once a month, we may have 1 or 2 cases. It's there. Look for it, high index of suspicion, you'll find it. I don't know in the old literature of Dr. Metwalli whether it was missed or not. I cannot really explain that, Saeed.
Dr. Wesam has a comment about this point. Dr. Wesam.
Yes, what you're saying, Dr. Saeed, is completely right. When I was training, and we used to encounter of a light chain cause nephropathy, then this was something for all the young trainees to see because it was uncommon. It usually was included in the slide seminars and so on. But up to, I think, more than 5 years back now, we have what we call the changing face of multiple myeloma. We definitely have a surge of multiple myeloma. We have so much increased cases. This is noticed everywhere in the world. And this is the discrepancy of what we were trained on and what we are seeing now. And as Professor Riyad Saeed just said, yes, right now, because of I see a case per week, not only 2 cases per month. So this is really starting to be very, very common. So we need a very high index of suspicion, and we need routine aspect, at least even without IF, on all our patients over 50 years. Also, although we are seeing myeloma now as young as 24 and 30 years old and 35, but still is more common in the older population. So yes, it changed. We're having so much more multiple myeloma than what.
Okay, thank you, Professor Wesam. Dr. Riyad. Yes, Dr. Riyad.
Yes. Now, so we have the monoclonal immune deposit disease, light chain deposit disease, CABA type. Now, you know, I'm not going to go through a lot of this, but how we treated this patient, I'd like to have from my colleague, Dr. Elkossi, how we'd like really to treat such a patient.
To be honest, usually we would like to go to the hematology to see what are their consensus about treating these cases, because they might, I mean, have got better approach to the patients with the, plasma cell dyscrasias. Before I go ahead with any treatment from our perspective, to be honest. Sometimes they are going for the bortezomib straight away. Sometimes they use something completely different. So all depending on the circumstances of the patients. So I don't know what you have done with your case. I'm not entirely
sure. Let me tell you, I looked about the treatment. You know, it's so widely. I put this slide. Chemotherapy, you know, you can have any combination. Dexa alone, melphalan, dexa, melphalan, cyclo, dexa, melphalan, as you'll see, proteasomab and other thalidomide and all. So really, it's, again, I agree with you now. This is, we are, as a nephrologist, would like to take good courses of hematology, oncology, nephro-oncology. That will be a trigger for that. As you'll see, it's a mixed bag. What we did really to our patient, okay, prednisone, at one point, I think we have plasma exchange for him that in the initial era, when we used to do good plasma exchanges on such patient, and then the hematologist read that based on the request of the hematologist, and he was given proteasomab Velcade with supportive blood transfusion, diuretics, painkillers, not non-steroidal. His symptoms, by the way, improved. He has moderate renal functional improvement. Serum creatinine from high level of 4 point something came down to 2.5, and then he was referred for autologous hematopoietic cell transplantation. So the question was to do plasma exchange or not, and under the insistence of our hematologist, really, we did the plasma exchanges, and it has some effect, whether really it was right or wrong, but basically prednisone therapy and protuzumab was really the cornerstone plus supportive management.
So I got the sense from your statement that you are not supporting plasma exchange. And I think this is the evidence nowadays. The evidence is very low for the role of plasma exchange in such cases, except if there is hyperviscosity syndrome. And another point on the chat, high cutoff membrane dialysis or medium cutoff membrane, the evidence is very low. Although the using high cutoff to filter light chain is exciting, but the evidence is still very low. And I'd like to hear from Professor Elkossi about these 2 points, plasma exchange and the high cutoff membrane dialysis.
I entirely agree with what you commented about. We don't use, let me talk about our management here in the UK. We don't use the plasma exchange in these cases, except of the hyperviscosity syndrome, some few cases with the immunotactoids, but nothing to do with the multiple myeloma or amyloidosis, to be honest, or light chain deposition disease. As regards the high cutoff value for this, the membranes or the dialyzers, to be honest, I am not entirely sure whether this will change the outcome or not. The renal outcome is reliable mainly on the myeloma outcome. And I'm not entirely sure whether this change of the membrane prognostically will change the outcome.
And for the chemotherapy, I think the trend or preference nowadays is toward the use of bortezomib, and some use thalidomide as well. So there is a resurgence of the use of thalidomide for such a case. But bortezomib, if it is available, and I think it's available everywhere, and it is now the standard for treating myeloma.
I highlighted it at the beginning, but to be honest, it is the hematology.
Yes, yes.
I agree.
Yes. What is going to be done.
Since 20 years, we are accustomed to treat multiple myeloma in our center. Nowadays, after the diagnosis is settled, we transfer the patient to hematology oncology centers. Dr. Dawlat Bilal, if you would like to comment. Or Dr. Saeed. Dr. Saeed Mohamdi.
Yes, thank you very much. And I think, honestly, from what we do in King Faisal Specialist Hospital in Jeddah here, that we have very active transplant, hematopoietic transplant program autologous, where we do at least 100 cases per year. And most of the cases, when we refer them to hematology, they adopt the transplantation policy. And the one who are not transplantable, they will be left on Velcade and other like thalidomide or something analogous to thalidomide. Yes. I must say something that, as you said, depends upon how the biopsy looks like. So if you have intensive, for example, cast formation, other thing, probably the reversal of the disease in the kidney is very little. And that depends on how the biopsy looks. Most of the patients, they have interstitial disease, they respond very well to steroid only. And I don't think that plasma exchange has a role except if there is an hyperviscosity syndrome. Thank you very much.
Thank you very much, Dr. Saeed. Dr. Dawlat. Yes, we hear you, Dr. Dawlat.
You hear me now?
Yes, we hear you very well. Go ahead, please.
I think for us, I think that we referred the cases to the hematologist first. And in many situations, we have to deal with the problems of the therapy they give. A long time ago, we had problems with the melphalan, and the melphalan was a very nephrotoxic drug. But I think it's mainly the hematology would deal with the case, and we do not interfere by plasmapheresis, definitely.
Thank you very much, Professor Dawlat. There is a question for Dr. Wesam regarding DNAB9 staining and fibrillar glomerulonephritis in such cases. I think it is removed. Dr. Wesam. It seems that we lost Dr. Wesam.
What's the question, Hussein?
Regarding this immune.
You always mute me, Hussein.
لا أنا ما أقدرش والله. The question regarding DNA GB9, which is specific for fibrillar glomerulonephritis.
No, this is an answer to a previous question on the chat where someone said that we need EM to diagnose the other spectrum of
nodular,
like fibrillary and immunotoxoid. So I answered that for fibrillary and immunotoxoid, you need a positive immuno. You need IgG and C3 because these are glomerulonephritis. And then you're going to have a monoclonal kappa. And that's a follow-up comment that we don't even need EM now to diagnose fibrillary GN. We can do it with the DNA JD9. So if in this scenario, the nodular glomerulosclerosis was positive for IgG and C3, then we would have considered one of the organized deposits, GN. We would have proceeded with the DNA JD9. And if it was negative, then probably it was an immunotoxoid, and then you will need EM.
Okay, thank you very much.
This is how. So again, it's immuno. You will proceed with the immuno first, and then the immuno will tell you whether at the end of the day you need the EM or not.
Thank you very much, Professor Wesam.
I'd like to add really one comment here about, if you allow me.
Yes.
You know, nowadays, yes, I think immunofluorescence stands really before anything else. And the classification, there is a nice article came in, I think in the Kidney International at one point, how really the perspective of looking about glomerular disease, immunofluorescence is the one really you start with, and you classify yourself according before the electron microscopy, because that's really the trend nowadays. It's quite important to have immune fluorescence. A kidney biopsy without immune fluorescence means nothing at all.
Dr. Wesam, I think that this was clarified by Dr. Wesam during the course. EM is not for diagnosis. EM not for diagnosis, as you mentioned in many cases, and it is reserved for certain situations. So I'm not going to mention them in details now. Okay?
Okay. Shall we proceed?
Yes. Dr. Muhammad.
Any other comments?
Dr. Muhammad Saeed, last point.
طبعا I would like to thank Professor Riyad for the elegant case.
Your comment, Dr. Muhammad.
Yeah, the bone marrow in this case, Professor Riyad, it was high. It was multiple myeloma from the start. It was unusual to find. It is not common, but to find multiple myeloma and MGRS, which is MIDD, it is not very common. And if the patient has from the start multiple myeloma proven by the bone marrow, the most common etiology for AKI, calcinopathy with the monoclonality in the urine, electrophoresis. If it is MIDD, most of these patients, they will have nephrotic syndrome with hypoalbuminemia, but the albumin, I think, here was normal. I'm not sure about this issue. Is it from the start high bone marrow turnover, or it is low bone marrow turnover?
The serum albumin was 2.9.
2.9 was low.
MIDD, yes, it was low. And MIDD patients do present with renal impairment because of the affection of the tubules, of the tubular basement membranes. So they present with a nephrotic proteinuria and with AKI. Your point about the discrepancy between the dipstick and the proteinuria, is that your point? From the pictures of the bone marrow, no, this was a dominant plasma cell infiltrate, definitely. So
yes.
It's a straightforward myeloma.
Yeah, thank you very much, Dr. Muhammad. Thank you. And I think because of the time,
let's proceed to the last
case.
Yes,
the last case, and we will take it rapidly, inshallah.
Yeah, okay. Sure. Now, the last case, this is unfortunate 83-year-old gentleman who was referred to us for evaluation of recent onset of acute kidney injury that required renal replacement therapy before he came to us. The patient history dates back to nearly 2 weeks prior to admission, when he developed bilateral flank pains and with moderate severity without radiation or any fever. The patient seeked medical advice, and he was given basically non-steroidal in the local hospital for his pains without any relief. Then he was treated by hujama, to relieve his pain, and with all these cups, and you see the sterile thing that he's been formed on his back. He is hypertensive but not diabetic. The patient noted a gradual decrease in his urine volume and became anuric within 48 hours. No gross hematuria or any significant prostatic symptoms. He was admitted to another facility as a case of acute kidney injury, creatinine 3.5, progressed to gradually up to 7. Hemodialysis was started there, via right IJ catheter. 3 days later, he was transferred to our place for further management and possible biopsy, because they scared to have a kidney biopsy on this elderly gentleman. When he arrived, his calcium was 6. He was on calcium supplement, on 1-alpha, and amlodipine for blood pressure. Physical examination, elderly male patient, not in acute distress. When we saw him, because he was sedated with painkillers, blood pressure 160/90, heart rate 84, weight 97 kilos, well hydrated. Cardiac exam, chest exam normal, no pericardial friction rub, normal abdominal examination apart from bilateral flank tenderness and marks of the hujama that looks inflamed. Mild to moderate lower limb edema and peripheral pulsations were intact. His hemoglobin was 12, white count raised, and hemoglobin A1C 6, ESR 35. He was AB blood group. Chemistry, serum creatinine 7 milligram, as I noticed to you, 1.837, 4.4, 5 point something, and that's in spite of dialysis. Calcium 10, phosphorus 4, total proteins, albumin not bad, normal liver enzymes, CPK was 230. His urine, specific gravity 10-10, white count few, RBCs 30 to 40, and 2+ protein, and this was catheterized sample. Protein creatinine 0.35 milligram per milligram. ECG, sinus, no evidence of acute injury, echo good left ventricular function, 54, and ejection fraction, no pericardial effusion, X-ray normal with IJ catheter in good place, ultrasound, normal size kidney, no hydronephrosis, increased echogenicity with prominent pyramids, poor blood flow to both kidneys by Doppler. Serology, all done and it's negative. Hepatitis B, C, ANAs, DNAs, C3, C4, ANCA, both MPO and PR3 were negative. Anti-GBM, again, negative. So we have very old gentleman presented with worsening acute kidney injury over a period of 10 days, severe flank pain bilaterally, required dialysis support, history of non-steroidal, hematuria with minimal proteinuria, normal sized kidney without obstruction, serology workup was negative. What's our differential diagnosis?
Dr. Elkossi? Dr. Elkossi?
Right, it's a bit challenging case. But what I would suggest, what about the differential of the full blood count? The eosinophils are normal or not normal?
The eosinophils, the white count, I can't recall really. We have high white count, you know, whether it seems to be related to his hujama, you know, it was looked really ugly looking, inflamed.
Right, okay. And what about the urine output? Is it anuric?
Very little urine output. He became anuric.
Anuric?
Yes.
And
so
you said
48 hours after the incident, he became anuric.
And you said that the anti-GBM is negative as well?
Yes.
Right. I would like to look into the vascular event, but the problem is that the ultrasound Doppler is not reliable at all about the blood flow, to be honest, in the native kidney in particular. So I would like to see what is going on with the vascular.
And if we have anuria, the differential diagnosis is either severe bilateral obstruction that was the ultrasound was not referring to hydronephrosis, so it is not obstruction. So I think renal infarction or vascular catastrophe is present. Severe renal venous thrombosis because of the pain maybe. So it is vascular mainly. Or I don't. If it is non-steroidal related papillary necrosis, it can be presented by this way. I'm not sure.
Bilateral papillary necrosis.
Yes.
Could be.
Yes.
Could be.
Yes.
Yeah, with the NSAIDs. With the NSAIDs, because the anuria, and the anuric acute kidney injury cases are very limited. Either the occlusion of the blood vessels, and there is no source of embolization here, or anti-GBM, which is negative, or obstruction, which there is no hydronephrosis. So it could be the papillary necrosis as part of the NSAIDs therapy.
So really the only thing was a poor blood flow. The radiologist commented on that.
I'm not sure, to be honest. I'm not sure about the reliability of the ultrasound Doppler in native kidneys, to be honest.
So if I put renal infarction in mind, in this case, I'm going to request a renogram. Because renogram will give us a very quick answer for kidney perfusion. Is it perfused or not? And we confronted a couple of cases with complete bilateral renal infarction. that was proven by a renogram. And this patient, one of these patients was transplanted in our center because of trauma, deceleration injury. من Arabic هو كان على سقالة، ما اعرفش سقالة بالانجليزي اتقال ازاي. Yes, وقع من عليها, so it is traumatic injury, deceleration trauma, and he everything is fine. After a couple of hours, starts to vomit, anuria, renal infarction by renogram, and it was deceleration injury without any bleeding, no perirenal, nothing. So he's unlucky.
To be honest, with this kidney function issue, obviously the CT angiography will be very helpful, but the kidney function will stop me doing that unless I put the biopsy.
Okay.
So I will go for the biopsy and see how it goes with the biopsy, and then.
I think that's nephropathology.
Yes.
Now, so, you know, you mentioned about all these acute kidney injuries. We're not going to go through it, but to me, the ischemia and the vascularity is the major issue for the time being. We have a kidney biopsy on this gentleman, 20 glomeruli microscopy, and 4 glomeruli on the immune fluorescence. Dr. Wesam, floor is yours.
Okay, this is an H&E stain. Someone was asking whether it is better to evaluate fibrosis on H&E low power. No, we don't evaluate fibrosis on H&E at all. We evaluate fibrosis with a combination of the PES stain and one of the fibrous stains, commonly trichome, or if the pathologist is using something else. But even though you can have an impression that you do have some form of chronic insult present on an HE stain, because you don't really see the tubules back to back.
What do you think about this area, Wesam?
And it seems that this core has an area which is not really clear compared to here, where you can see that you have globally sclerosed glomeruli and some interesting infiltrate, but then we have this area. Then we have a higher power. This is an infarcted area.
Yes, infarction.
Yeah. This is a medulla, and yes, again here you can see that you can not see any details. You can also only see this pink material, as well as in this core as well.
Ghost. It's a ghost.
Ghost
yes,
of this.
Ghost, yes, of the tubules. There is no glomeruli in this area. Maybe this one, but I can't see well on the low power as well. And you have definitely. Here you go. Now this is the infection. So this is what you call cortical necrosis, which equals renal infarction. You have necrotic glomeruli, and glomeruli usually maintains their outline. And here also you can see it. And then you have necrotic tubules all through. We don't see any nuclei, so there is absolutely no blue color here. So this is cortical necrosis.
So I remember one case reported in CJASN about non-steroidal anti-inflammatory drug induced cortical necrosis. So it seemed that it is non-steroidal induced. Dr. Riyad.
Was it due to the functional spasm or what, Dr. Hussein? So extensive vasoconstriction?
Yeah. But I'm not remembering the discussion of the case, but the case was old man with cocktail of polypharmacy. And at the end of the discussion, yes, it was cortical necrosis because of non-steroidal anti-inflammatory drug use.
You can see even the globally sclerosed glomerulus here is necrotic as well.
Okay.
Before I consider the causes purely because of NSAIDs, I would like to make sure about the echo is fine. Yes. There is no issues about that. I'm sure that you have done that, isn't it?
Yes, it was done, and it's normal. Ejection fraction is
good. Echo was mentioned.
It's regular sinus rhythm.
No cardiomyopathy, no thromboembolic manifestation.
Thromboembolic phenomenon. Just exclude the thromboembolic phenomenon, and he hasn't had any procedures recently, like angiography. I mean, coronary. He
was brought from home to the hospital with that history, flank pains and others, and he was given treatment, as I mentioned earlier.
Right, and Sam, you don't have any cholesterol embolization, as you can see from obviously.
No, I don't see. I thought about it, of course, in relation to his age.
Yeah.
And then this is something we would consider, definitely. but we don't have a clear picture of the blood vessels. But obviously, it doesn't seem, at least from the pictures we've seen, it doesn't seem that there is any form of cholesterol emboli. This is the rest of the kidney, and it seems that it's already somewhat a chronic kidney because the tubules are slightly atrophic. You have definitely some interstitial fibrosis, even on the H&E levels. You have this what's thyroidization of the tubules, and the gloms appear to be slightly ischemic. There is nothing wrong with this glomerulus. This is just red blood cells. It's expected for the tissue which is close to the infarcted area to be slightly congested, fusion injury, a form of compensation. So again, you can see that the gloms are slightly congested, which is accepted within the context of having renal cortical necrosis. And then again, this is a necrotic globally glomerulus starting. This is between the infarcted area and the viable area. And all what I can see in the viable area is that you only have evidence of some form of chronic damage, which could be age-related, of course.
Usually, we would like to do the thrombophilia screen in these circumstances again before we conclude that it's purely because of NSAID.
Yes, we should do.
Okay, this is an arteriole, yes. And you can see here that we have an arteriole, an interlobular artery, and there is, yes, it might be thickened, but there is nothing else in it. I mean, you don't have inflammation, you don't have necrosis. It seems that it could be slightly hyalinose. I really can't tell on an H&E, and the focus is not that clear, but maybe there is something in the wall. This is also what, a glomerulus?
I don't know. I don't know.
Yeah, this is a globally sclerosed glomerulus as well, and this is what's left of the arteriole. Sometimes you get this pattern.
This is again another glomerulus?
Yes, this is another globally sclerosed glomerulus.
What do you think about this?
And this is definitely a thickened blood vessel.
Yes.
Definitely.
Yes.
But there is nothing in the blood vessel. There is no necrosis, no inflammation, no emboli, no cholesterol emboli, no fibrin emboli. It's just a thickened blood vessel, which of course would help. If this is already a chronic kidney or a kidney with an ischemic insult, then any insult can precipitate what happens. Not common, of course, but would be more prone for such an ischemic insult. Okay, this is a globally sclerosed glomerulus, and the infiltrate you see around is non-specific because this is a typical reaction of the kidney to globally sclerosed glomeruli. So whenever you have globally sclerosed glomeruli, you will find them surrounded by a non-specific interstitial infiltrate. So this does not mean that the patient has interstitial nephritis.
What do you think about these two blood vessels, Wesam?
Yeah, okay. Within these two blood vessels, I would consider a healed vasculitis.
You consider what?
Actually, a healed vasculitis. It can give you this this more of a fibro antenna thickening rather than your regular atherosclerosis as a healed form of necrosis or previous inflammation of the arteries. This one could be related to hypertension and so on, but this one is quite peculiar actually.
This one?
With all this edema, yes, in the fibroantenna and so on.
Same thing.
Yeah, and only congested glomeruli.
This is trichrome.
This is trichrome. There is nothing.
And we did amyloid. This is just a control for you. That's the Congo red, and this is the amyloid control, how positive the apple green perfringens that we have, and it's negative in our patient. So really, there is no evidence of amyloidosis also. We do it routinely in all our patients. Okay, so what do you think your final touch and possible diagnosis looking about this?
I would diagnose it as cortical necrosis with within the kidney with ischemic glomerular changes, global sclerosis, and arteriosclerosis, and to consider if I don't know the serology of the patient,
all negative.
I think, yes. So nothing. If the patient did not have the serology, I would have considered possibly an ANCA. Although no, this is not. But this is not typical ANCA presentation actually. This is a cortical necrosis, just a cortical. It's not even a total infarction. This is just cortical necrosis.
When I jump into the diagnosis of non-steroidal, I imagine that all serology testing for vasculitis are negative. So
it is. I think they mentioned it. Yes, Professor Said has mentioned it. Yeah, it was excluded.
Yes.
Dr. Mohsen. Dr. Mohsen, what do you think?
Sorry? As I'm saying, we have to exclude all the possibilities of having these infarctions. First of all, you have mentioned that the echo was fine. There is no AF. There is no thrombotic phenomenon. The cholesterol embolization on the biopsy is not there. And the thrombophilia screen, antiphospholipid antibodies needs to be screened before we go to the final of the NSAIDs as a cause of the problem.
Agree.
To be honest, I mean, sorry?
Agree.
Yeah.
The question to you, Professor Elkossi, what about the radiology evaluation? Do you like to have CT? Yes, because it was asked, yes, MR or CT or whatever you like to add.
To be honest, I mean, sometimes the biopsy is selective. So when you have taken, say, for example, the biopsy, you might have taken it from an area without any infarction, unless you have got the kidney, all of it has been infarcted. I would go, although it is too risky for a patient with acute kidney injury, still the gold standard would be CT angiography, to be honest. And with the proper hydration, if he is going to have the, interstitial problem from the contrast, still we need to have the diagnosis. Has this patient got any main renal artery problems, or it is just only pure segmental arteries? I don't know, all depending on the CT angiography, to be honest.
Dr. Dawlat? Dr. Dawlat? Unmute yourself, Dr. Dawlat. Because she raised her hand, and I'd like to hear from Dr. Wesam. Not typical of ANCA. Yes, I agree with this point. Okay. Dr. Riyad, do you like to...
But for you, this just what really to sum it up, what we have really when we have infarction, renal infarction, or, as I heard from Dr. Elkossi, you have to look about cardiogenic, so relation cardiomyopathy, valve, and other endocarditis. Renal artery, I think we have to remember, injury, if you look about in this study, it was published in 2016, American Journal of Kidney Disease. They have the cardiac issues, the renal artery issues, again, thrombophilias, hypercoagulable state, we should always really look for. And then there are a group of patients, idiopathic, look about 132 patients, really.
50%.
Yes, they have, there is no reason you can spontaneously, but I agree we should look for everything. Concerning about the angiography and imaging studies, this, if you'd like to do with this patient, for example, he's totally anuric, he's on dialysis, the risk of damage is already there for his kidneys, likelihood to recover with this kind of picture, it's unlikely, and I don't see any trouble for doing CT angio of the renal vessels, and I think they did not do it before. The trouble why it has been missed this, because nobody thought about it. In addition, the clinical symptom scenario that the patient presented, usually it missed like more common things like pyelonephritis, like renal colics, like musculoskeletal pains, and that's really what happened. Unfortunately, if you don't think about it too early, that's the end result of this. It's a sad situation.
Okay, so if you have a choice, you will do CT angiograph for this patient?
I will do it. I will do it looking about the vascularity in absence of any other things. But this patient was referred for his primary nephrologist and other facility. Please, can you do for us a kidney biopsy?
Okay, so I think kidney biopsy is indicated in this case after thorough evaluation of serology and all thrombophilia screen. And if this is my case, and the patient is totally anuric, I do renogram in 1 hour. I know the kidney status perfused or not. If it is completely non-perfused, so I know it is non-perfused. Doing CT or MRI, I think the new generations of gadolinium, second and third generations, the risk of nephrogenic systemic fibrosis is very remote, even nil. And so we can do MR with gadolinium with second or third generation. But CT, if we prefer CT angio, that may be done for this case, CT should be done before dialysis because of afraid of idiosyncratic reaction from accumulation of iodide with iodinated contrast media. Dr. Elkossi.
I don't have anything to add, to be honest.
Okay. Dr. Riyad Bey.
Well, I think this is here. Unfortunately, this patient, continued to be a dialysis-dependent individual, and that's the tragedy what we have in such patients when really we miss that. It has been missed. Okay, so that's a case of acute infarction in a patient bilateral. I'm sure, because otherwise he's not going to be anuric and he's a total dialysis dependent. He did not recover his kidney function.
Dr. Tantawi?
Really, I am impressed from the 3 cases, but as regards the elderly, we confronted with a lot of cases with EKI. We have to exclude first obstructive uropathy by many issues. And another concern, which is very, very important, is the hydration states. Our elderly patient haven't the proper way to be well hydrated, and especially in some circumstances with a little bit of AKI, with nausea or vomiting, and no replacement as negligence, and a lot of issues. My case, in this case, last case, I think the issue here was with nausea, vomiting, and fluid loss, that the consequences is acute cortical necrosis. Unfortunately, the case will be for permanent dialysis. This issue, because also the residual kidney function for the elderly is not so enough to matches with this dilemma. And the last month I confronted with a young patient, is around 30 years, after an intervention for deviated nasal septum. After the surgery, he suffered from severe hemorrhage, and the condition ended by acute cortical necrosis in a young elderly patient, and is now is prepared for preemptive renal transplantation because there is no recovery after the mysterious insults that he had. I'm very satisfied from the previous 3 cases. ده تطبيق عملي اللي احنا بنقوله الفترات اللي فاتت. انا بشجع الاتجاه ده دكتور حسين بتاع الحالات، لان هو ده الواقع وهو ده
this is why Dr.
اللي هيفيدنا كلنا.
This is why Dr. Tariq, I like to hear from you, because this is a call from all nephrologists. We need cases rather than lectures, long lectures. Yes, it is fine, but we need complementary cases. And I think today, this is the gold standard, the standard of care of presenting casing. And I preferred to start with Professor Riyad Saeed, because I asked my colleagues in MD nephrology to prepare cases. So this is a style of cases that we would like to hear. So I think this is a role model for case presentation.
والامانه الشديده يعني انا شايف في مستشفى الدكتور رياض the optimal care ان انا
مش هنعمل دعايه بقى، مش هنعمل دعايه.
لا ده واقع، لا حضرتك ده واقع. ما انا ممكن يبقى بقول ليكتشرز، ببقى عارف اكاديميك كتير، لكن انا عايز ابلاي او عايز افيد المريض بتاعي. هو هنا حصل افاده للمرضى. انا سعيد جدا بالثلاث حالات دول يا دكتور رياض.
دكتور I'd like to hear from Dr. Fuad Riyad Saeed because I wanted to thank him very much for collaboration, for downloading Zoom, for helping from the technical points to Professor Riyad. Dr. Fuad.
Fuad?
It seems that...
I think he's not here. I think
okay. Dr. Last comment to Dr. Faisal Shaheen. Professor Faisal.
Thank you very much. Actually, it is very nice case and it is very informative. And I am sure that many colleagues will learn a lot from this, especially we misdiagnose many cases, or we don't reach even to clue what could be this case. But this teaches us that we should look more wider and think about biopsy more, and even not like before we just take the EM also only, but we can go further for immunofluorescent, and which can diagnose almost around 90 to 95% of cases without electron microscope. So even if we don't have facility of electron microscope, still we can go ahead with the biopsy, and it can clear many cases which we missed. I am sure that we were missing a lot of cases with diseases, which is important and can be treated. Thank you very much. I enjoy this lectures today and the cases today, and I appreciate all the comment which happened from all our colleagues, and I hope that we can see this again in different occasions.
Inshallah. Thank you very much, Professor Faisal, and Dr. Saeed Al-Ghamdi. This is the last. This is the last and the last.
Okay. Thank you very much. As usual, this is a very interesting case, which actually I would say that I have similar case before, similar to Professor Riyad Saeed case, but unfortunately I did not do biopsy. He developed acute kidney injury with anuria, and we anticipated that probably it's a vascular injury, and I think we have in the future probably to look into this case and the relation also to NSAID, because you don't know exactly what's going on and what's the effect of venous congestion here. By the way, this case, you see there is both chronic and acute changes, and I assume the chronic changes due to the age, actually, that probably this man is about 80 something plus, and presumably his background is having lots of glomeruli has already been demised from the vascular process or aging process. But what I'm saying that Professor Riyad Saeed is really brave enough to do kidney biopsy in somebody who's that old and with dismal prognosis, but this will add a lot to our scientific information and our experience. So probably in the future, I will be following his steps, and I think we have just to collect these cases. Thank you very much.
Before closing this session, I'd like to hear from Professor Elkossi, just the last statement. Dr. Elkossi.
Very interesting. Obviously, I can't add any more comment to what has been added already. For the last case, I mean, because I remember a similar case exactly was what has happened. When a patient presenting to us with the acute abdominal discomfort or pain, the first step to do is just do it in the accidental emergency CT scan. And we have got the diagnosis of the infarction from the CT scan done in the A&E prior to have the biopsy. So anyway, so this patient has had the ultrasound scan and has been referred from another facility, which explains why he hasn't had this in the beginning.
There are a couple of cases reported in literature about pain, anuria, defect in kidney perfusion by ultrasound, and CT showed the diagnosis of nearly non-perfused kidneys, and the MRI was the diagnosis because of signal restriction, referring to systemic zygomycosis diagnosed by this cocktail of radiology, non-perfusion by CT and Doppler, and restriction, because restriction sign means excessive iron present in the fungus. So these are rare cases in the literature. So Dr. Wesam, we want to hear from you last statements about this Zoom. We want to appreciate your efforts.
And as usual, maybe
Fantastic.
not everybody, yes, maybe not everybody knows, but me and Professor Riyad Saeed have been partnering with this CPC sessions for a long time. I'm not going to say how many years, since I was very, very, very young. But as usual, it's a pleasure. It's always a pleasure, and it's an honor always to be invited by
very nice couple, yes.
By Professor Riyad. Yes, we've done this live a lot. We hope that we can go back to physical presence, but this was a great alternative, and very enjoyable, very informative and educative for everyone, with quite challenging cases, touching the basics, and still always have a twist. Thank you for the invitation and for being blind to the biopsies. I think I did okay.
Yes, and, perfect, Dr. Wesam. Perfect. I was asked by Professor Saeed Khamis, is there any harmony and the cases were presented to Professor Wesam? I said to him, it will be blind because they accustomed to do this game all the time.
We're accustomed to this.
And it is very interesting game. I would like to thank and appreciate your presence, Professor Riyad. Really, it is very enjoyable, very fruitful, and I think it is a very nice tutorial for myself and for all colleagues how to present the cases in a very respected way. This is a very teaching cases that make us, all of us, excited by these cases. The mic is to you to say the last statement.
Thank you. First of all, I'd like really to thank all the audience with their patience with us for this long time. Secondly, for the Egyptian Society of Nephrology Transplantation for hosting this really, and Dr. Elkossi, from England. And finally, I'd like to say really Wesam being really so helpful here and during this session. I totally told her these cases are blinded, and when I chatted with her yesterday, told her you're going to be surprised, but I will help. You will be on the spot. Please take the task. She accepted without hesitancy, really, to take the task. And Wesam, you did a very fantastic job, as usual. Thank you very much, and looking forward more and
more. And I ask you, Professor Riyad, for me, yes, please, this is an invitation, even if it will be done on monthly basis or bi-weekly basis.
I'm ready.
I'll be happy.
We'll go pathology. We'll talk about this.
And one of our friend, Dr. Tariq Tantaw, want to welcome you again. I cannot say to Dr. Tariq enough. دكتور طارق.
بصراحه وده اللي انا كنت عايز اقوله، ان انا شايف في كيس نمبر 5 انا انجود ان انا اسمع معانا.
لا ما
فانا شايف ان احنا
نمبر 5 6 7 لكن تايم ريلي وي هاف تو ستيك تو
هو دكتور طارق
فور مور كيسز.
هو دكتور طارق عاوز
لا ده عشان نقعد مره ثانيه حضرتك يعني.
احنا هنقعد مره ثانيه وثالثه ورابعه ان شاء الله.
ان شاء الله. بس we're going to have a piece of nephrology transplant, transplant patient later on with the arrangement with Dr. Hussein.
ان شاء الله.
Thanks a lot really for this really well orchestrated meeting. really
شرف لنا يا دكتور رياض، شرف لنا نتكلم بالعربي في الاخر يعني. شرف عظيم لنا ان انت حضرتك معانا. حضرتك بهذه السينيوريتي بتعلمنا ازاي نتكلم وازاي نقدم حالات. انا سعيد، ايام سعاده بقى باللغه العربيه الفصحى، وسعيد طبعا بوجود الاحباب كلهم وبوجود الدكتور محسن القوسي من انجلترا.
والله انا اللي سعيد جدا.
دكتور هشام، يعني ده ميتنج رائع.
طبعا عايز اقول مشاركه فيصل وسعيد من السعوديه.
طبعا
always سعيد used to be the star for our pathology meetings when he used to be always on the spot.
Yes.
Among 150 individuals, he's the only one really I used to pick on.
يعني خلينا نفتح عليه تاني خلاص اهو. اخر حاجه دكتور سعيد. دكتور سعيد لو معانا.
شكرا جزيلا والله.
عشان ناخد البركه، ولو في بيت شعري نختم بيه.
والله صراحه انا بالفعل يعني بتعلم كثير من الحالات هذه، والكونفرنس هذا السي بي سي حق البروف رياض سعيد معاه من حوالي 15 14 سنه واحنا بنتعلم كثير.
هو
والبروف
ماسترنج
رياض
القصه دي ماسترنج
وماسترنج انا بالنسبه لي the best part of the Egyptian the Jordanian Society of Nephrology is Prof Riyad Saeed when he really present his cases. That's the يعني one of the best thing that we wait from year to year to hear it. So I really thank him very much and I
وان شاء الله هنحاول نجمع ما بينه وبين الدكتور غنيمات ان شاء الله قريبا باذن الله ان شاء الله، لان احنا طبعا كل الحب للجميع وبشكركم، وان شاء الله تلاقوا الفيديو على اليوتيوب الساعه 10 قبل الساعه 10 صباحا في الغد ان شاء الله. بكره معنا لقاء غدا we have a special meeting with Professor Ahmed Halawa and with Liverpool team. It will be applied cases scenarios about plagiarism in literature. So tomorrow ان شاء الله 8 بتوقيت القاهره. شكرا جزيلا ونلقاكم على خير والسلام عليكم ورحمه الله وبركاته.
وعليكم السلام ورحمه الله وبركاته.
شكرا جزيلا.